We have discussed the physiologic significance of serum sodium, as well as discussed disorders of hyponatremia and hypernatremia. In this final section, we will discuss the clinical significance of potassium and discuss hyperkalemia and hypokalemia, or disorders of potassium balance. Potassium is the major intracellular cation. As you recall from the first lecture, cations are ions with a positive charge, and sodium was the major extracellular cation. Well, potassium is predominantly located within the cells. The normal serum concentration of potassium is between 3.5 and 5 milliequivalents per liter, whereas the intracellular potassium concentration is approximately 150 to 160 milliequivalents per liter, so just about opposite of the serum sodium. Serum potassium has many important physiologic functions. It regulates intracellular fluid osmolality, whereas remember sodium regulated extracellular fluid osmolality. Potassium assists in intracellular electroneutrality. It provides balance for that intracellular electroneutrality in relation to hydrogen and sodium. It's required for glycogen deposition in liver and skeletal muscle cells. It's important for maintaining the resting membrane potential, which is important for transmitting and conducting nerve impulses, maintaining normal cardiac rhythms, as well as maintaining skeletal and smooth muscle contractions. Potassium homeostasis is maintained by renal excretion. It's also excreted to a lesser extent in stool and sweat. The amount of potassium that is excreted varies based on serum potassium concentrations. When serum potassium concentrations increase, then renal excretion will increase. When serum potassium concentrations decrease, then renal excretion also decreases. Renal excretion also varies based on renal flow rates. Changes in the flow rate of filtrate through the distal tubule will affect secretion, such that increased flow rates, such as can occur with diuretics, will lead to increased potassium secretion. Aldosterone, which we talked about in the sodium lectures, also affects potassium levels. When potassium concentration is increased, aldosterone is increased, which leads to increased potassium excretion into the urine. When potassium concentration is decreased, then aldosterone concentration can be decreased, which will then decrease potassium excretion. As I said, potassium is also lost through stool, approximately 5 to 10 milliequivalents per day, and sweat, between 0 and 20 milliequivalents per liter per day. The potassium lost via sweat is usually quite low, except under extreme physical exertion. We'll first talk about disorders of excess potassium, or hyperkalemia. This is when you have serum potassium concentrations greater than 5 milliequivalents per liter. This can be caused by a variety of etiologies, including decreased renal excretion, which can occur with chronic kidney disease and end-stage renal disease. It can also occur with hypoaldosteronism, or decreased aldosterone levels. It can occur when there's shifts from the intracellular to the extracellular space. Potassium, as we said, is normally intracellular, but there are various conditions that can lead for the potassium to go from the intracellular space to the extracellular space, causing an elevation in the serum potassium levels. This can occur with digoxin. It can occur when there's massive tissue necrosis or tissue death that leads to leaking of the potassium. Excess potassium levels can also occur when there's excess potassium intake. It can occur with certain medications, as well as pseudohyperkalemia. Pseudohyperkalemia is when there is shifting of the intracellular potassium to the extracellular compartment following venipuncture. If pseudohyperkalemia is suspected, the lab should be repeated and confirmed. Clinical presentation of hyperkalemia is the same, regardless of the underlying etiology, just as it was with the sodium disorders. Arrhythmias are very common and can include sinus bradycardia, sinus arrest, ventricular tachycardia, ventricular fibrillation. Ascending paralysis can also occur, and the paralysis can even include diaphragmatic paralysis and respiratory failure, so that can be quite significant, obviously. Diagnostic evaluation always begins with complete patient evaluations, and this can include a medication history to try and identify sources for excess potassium levels. obtaining a dietary and diet supplement history, looking for risk factors for kidney disease which can contribute to hyperkalemia, assessing for reduction in urine output. Oliguric or decreased urine production associated with renal failure is associated with the highest risk for hyperkalemia. Serum electrolytes, not only including serum potassium levels, but also other serum electrolytes, including magnesium. Magnesium can be a cofactor for potassium absorption. Thus, it can be important to look at magnesium levels, and we'll discuss magnesium further in upcoming lecture series. Looking at the renal function to determine if the renal function could play a role in the abnormal potassium balance. EKG can be helpful. There are very classic EKG changes associated with hyperkalemia, and these are changes that progress from tall peaked P waves to loss of the P waves to a widened QRS complex to a sine wave pattern. One of the problems with EKG findings, however, is that EKG findings are notably insensitive in patients that have chronic kidney disease or end-stage renal disease. And of course, patients with chronic kidney disease and end-stage renal disease are at the highest risk for hyperkalemia. Many other additional tests can be performed to further evaluate hyperkalemia depending on the clinical situation. These can include serum and urine osmolality, CBC, urinary pH, and urine sodium levels. Treatment of hyperkalemia. Severe hyperkalemia and or the presence of EKG changes are a medical emergency. These should be treated with hospital admission, continuous cardiac monitoring, and immediate treatment to lower the potassium levels and to stabilize the risk of cardiac arrhythmias. It's important to identify and treat the underlying etiology. Ways to lower the potassium levels can be administering medications that encourage the redistribution of extracellular potassium into the intracellular space. Medications that promote the intracellular movement of potassium include insulin and beta agonists, including inhaled bronchodilators like albuterol. You can also lower potassium levels by potassium removal. This can be through the administration of diuretics and or dialysis in severe cases. Calcium gluconate can be administered to reduce the risk of cardiac arrhythmias. Calcium gluconate antagonizes the cardiac effects of hyperkalemia. The effect of calcium gluconate can begin within 1 to 3 minutes and can last 30 to 60 minutes. If the patient's underlying situation with the EKG changes and or the hyperkalemia has not corrected, then the dosages of calcium gluconate can be repeated. Complications of hyperkalemia can be severe and include cardiac arrhythmias as already described and can be associated with increased mortality. Thus, treatment of hyperkalemia is critical. On the other end of the spectrum is hypokalemia, or low serum potassium levels. The definition of hypokalemia is serum potassium levels less than 3.5 milliequivalents per liter. This is a common condition and is the second most common electrolyte abnormality in hospitalized patients, occurring in approximately 20% of hospitalized patients. Etiologies of hypokalemia can include insufficient dietary intake, fruits, vegetables are sources of potassium. Hypokalemia can also occur when there's shifting from the extracellular to the intracellular space. This can occur with medications like insulin or beta-adrenergic stimulation, as we discussed. It's been noted that self-limited hypokalemia occurs in over half of trauma patients, and it is felt to be related to enhanced release of epinephrine, which then leads to increased intracellular shifting. Beta-2 agonists, including bronchodilators, can lead to hypokalemia. This is something that we use therapeutically for treatment of hyperkalemia, as described. Extrarenal potassium loss can occur through the GI tract with diarrhea. Normally, only 5 to 10 milliequivalents per day of potassium is lost in the stool, but up to 100 to 200 milliequivalents per day can be lost in cases of severe diarrhea. Renal potassium can also occur with states of increased aldosterone or diuretics. Clinical manifestations of hypokalemia include prominent effects on the cardiac, skeletal, and intestinal muscle cells. Severe symptoms generally occur only with potassium levels less than 2.5 milliequivalents per liter. Muscular effects can include muscular weakness, fatigue, muscle cramps, flaccid paralysis. GI effects can include constipation and ileus, and cardiac effects can include both ventricular and atrial arrhythmias. The diagnostic evaluation, of course, begins with a complete patient evaluation, focusing on medication use, dietary habits, and symptoms suggestive of a specific etiology. Assessment of serum electrolytes, including not only potassium but also magnesium as well as other serum electrolytes, can be helpful. Assessment of renal function and urinary potassium levels can be useful. The appropriate urinary response to hypokalemia would be retention of urinary potassium, thus excretion of increased amounts of urinary potassium would be abnormal. Urine osmolality levels can be assessed, and they can be used to calculate transtubular potassium gradient. This is a simple and rapid evaluation of net potassium secretion. Elevated transtubular potassium gradients can suggest renal potassium loss, and it can even further differentiate where that potassium loss is occurring within the kidneys. EKG changes can be present, including broad, flat T waves, ST depression, or QT prolongation. Additional tests to consider based on the underlying clinical status could include a CBC, urinary pH testing, serum osmolality, urine calcium levels, thyroid function tests, and aldosterone levels. Treatment of hypokalemia, it's important to identify and treat the underlying etiology and then to replace the potassium. Oral potassium chloride is the mainstay of therapy. However, there are other preparations that can be indicated in certain situations. For instance, if a patient has a combined potassium and phosphate deficit, potassium phosphate may be indicated. If a patient has a coexisting metabolic alkalosis, then potassium bicarbonate or potassium citrate may be considered. It's important to minimize potassium loss, and you can do this by adjusting medications that have an effect on potassium, such as medications that affect the renin-angiotensin-aldosterone axis. Complications of hypokalemia, it is associated with an increased in-hospital mortality, and treatment-resistant hypokalemia can be caused by concurrent hypomagnesia. As previously stated, magnesium can be a cofactor for potassium absorption. Thus, if you have magnesium deficiency, it can lead to an inability to maintain normal potassium levels. We will further discuss magnesium in upcoming lectures. And now we come to the final two discussion questions for this lecture series. Which of the following does not play a significant role in potassium homeostasis? Is it A, aldosterone? Is it B, antidiuretic hormone? Is it C, renal flow rates? Or D, serum potassium concentrations? And the answer is antidiuretic hormone. We talked about antidiuretic hormone and its role in relation to serum sodium levels as well as water homeostasis, but it does not play a critical role in potassium homeostasis. Which of the following conditions would cause a shift of potassium from the extracellular space to the intracellular space? Aldosterone, insulin, alkalosis, or thyroid hormone? And the answer to this is insulin, and as you recall, we can use this to our therapeutic advantage for patients that have hyperkalemia. We now have a few moments to take any questions that you may have in relation to potassium and its physiologic role and/or disorders of potassium balance. Thank you for listening to this lecture series, and this concludes the Week 3 lecture content.